Two questions for the Professor Kwong. Yeah, thank you. Welcome. Well, very congratulations to Hong Kong Smile. I have two questions for you, and number one is, I know that as you said, maybe half of your patients could enjoy sustained CR. So, how many patients of you provide the booster radiotherapy to the primary lesion? And I want to know how many of them can get to the EBV negativity. And second is that I know that the two key things for the NK-cell, especially nasal type, one is the angio-invasive, the other one is the EBV. So I want to know, is there any possibility to upgrade your SMILE by just the Dr. Coleman said, anti-angiogenesis strategy, or give the EBV cytotherapy? Thank you.
Thank you very much, Jeffrey. To answer your first question, we will always irradiate if the tumor is amenable to radiotherapy. So patients who have localized lymphomas will get radiotherapy. But obviously, patients with disseminated lymphoma cannot get radiotherapy because we can't irradiate every area. So to answer your question simply is people with localized tumor will get radiotherapy, every one of them. I haven't got the figures here for you, but that's the general approach. Second question is, I don't know whether anti-angiogenesis drugs will work in this situation. That's a very good suggestion. It's something that I can think about later on. Epstein-Barr virus, unfortunately, targeting Epstein-Barr virus with antiviral agents has been disappointing. We have not had any. In the past, we've tried it on a number of patients with refractory disease. That was before we had this protocol, and the antivirals just didn't work. So the answer is no. We have not actually had any success with that.
Just a quick, go ahead, please.
Then go to the EBV negativity.
Sorry?
You mean you monitoring the blood test?
Yeah. You mean the I just said that we had a definition called molecular remission. Molecular remission meaning that we cannot measure EBV DNA in the blood, and these patients who enter CR are all EBV negative in the peripheral blood.
I just had a quick question for Dr. Kwong. It seems like very, very important to achieve a CR in these patients because less than a CR, essentially, patients will die. So in a patient who had, you mentioned a couple patients who had a PR, or I would just put it out there, patients who say would relapse, what would be an effective drug combination or therapeutic approach for those patients? Or would you take a PR, how would you get them to a CR if necessary?
Well, that's a very difficult question to answer. With the SMILE protocol, patients who had only PR after 6 courses almost invariably would die in the long run, and we don't really have any effective treatment, unfortunately, for these patients. I think 1 or 2 patients have been transplanted, but as I showed you on the graph, when patients are transplanted in PR, the outcome is still very poor. So I'm sorry, at this point in time, we don't really have anything very good to offer to these patients.
Thank you.
Swami?
So this question is for Dr. Yunus. One of the big problems we have in Hodgkin's, though it's curable, small percentage of patients, anywhere from 5 to 10%, are primary refractory. So there are strategies, PET-based, either dose escalation from ABVD to BACOP or the European version of de-escalation. But from a biology perspective, and also from it's always hard to look at the Reed-Sternberg cell and try to find out the characteristics. It's like looking for a needle in a haystack. But from a biology perspective, and also given the role of SGN35, what are your thoughts on these small percentage of patients? We really have a hard time dealing with some of these primary, as you know.
So for now, primary refractory disease, and I agree with you, it's a difficult situation to treat. The SGN35 right now is not approved for one prior regimen, 2 prior regimens. So you have to give ABVD if you're refractory. You still have to go through the ISO GND. Then you can give SGN35. This is on label. That's how you do it. But my hope that at least from preliminary data, from even in the phase 1 with ABVD or AVD, everybody's going into a CR so far. I'm sure there's some of them would relapse in the future. But it looks like that the number of primary refractory disease hopefully will substantially decrease if we can show in the randomized trial that a frontline regimen that includes brentuximab is successful. Until then, I think you still have to go through standard salvage regimens and then think about incorporating SGN35 in pre-transplant setting.
Okay. I mean, from a biology perspective, do you have any insights on the role of chemokine receptors in this particular setting? Perhaps it's not the chemotherapy that's not getting in, but maybe the stromal interaction that may be playing a role.
Yeah, it's a good question. And a short answer, no. There's really no clear answer why some patients would have primary refractory disease. So there's several prognostic factors that you use some biologic factors to predict, especially like the monocytes in the microenvironment, for example, that it shows that if you have a high number of monocytes in the microenvironment, you probably have a lower chance of being cured. How this works, no one knows. And my guess is that monocytes may provide some survival factors, including BLyS and probably CD40 ligand to the malignant cells, but this is really a hypothetical issue, and no one can prove this in scientific way.
But the infusion of these macrophages and these monocytes, by the way, really give off angiogenic factors, which really causes neoangiogenesis. And that may be one role why they have shown that when you have the presence of these monocytes and macrophages, why people have a much poorer prognosis. So angiogenesis plays part of the role. I don't know what else is playing a role as well.
Thank you.
I have a quick question, actually, for Anas. With respect to the targeted therapy, I know that in the past there has been some hypothesis that you led actually an area looking at perhaps the role of normal B cells within the microenvironment within the Reed-Sternberg cell. I was just wondering if you could comment. I'm wondering where it stood. I know there was a trial looking at maybe rituximab with combination chemotherapy. I was wondering what your opinion is.
Right. So there's two ABVD plus rituximab trials, both phase 2. Both are actually in press right now in Blood, going to be published in the same issue. One was single institution from our center, about 85 patients treated. And if you look at the outcome based on IPS prognostic factor, actually the outcome is better than what you expect from ABVD alone. Again, non-randomized trial. And then the group from Hopkins did a multi-center trial using the same approach and showed almost identical results with us in the CR rate and progression-free survival. Now, I can argue how this Rituxan work. Our initial hypothesis was that depleting reactive B cells from the microenvironment may disrupt the microenvironment, some growth factors, and may make the tumor cells more susceptible to chemotherapy. Since we started the trial, as you remember, that the Rich Ambinder and his group reported that the putative Reed-Sternberg cell stem cells also may express CD20. Mm-hmm. And there's also some data to suggest that if you deplete B cells, you can take the breaks from the immune suppression, so T cells may become more active against tumor. So there's different ways it may work, but so far, at least in the 2 phase 2 trials, the data looks promising. Towards now, there's a multi-center randomized trial comparing ABVD with IBVD that we hope that will complete it in a couple of years from now.
I wonder if actually the combination of SGN35 and another, like a CD20, would be actually a rational combination.
I agree. I mean, these are not mutually exclusive because the mechanism of action is completely different.
Right.
One last question for Dr. Kwong. Dr. Kwong, why do you think NKT lymphomas are so prevalent in the Asian population and not as prevalent in the Western population?
Well, that's a very good question. In fact, they are not only prevalent in Asian populations, you also find South American patients being affected with this particular tumor. And if you look at the world map, my personal, you also find this lymphoma in the Alaskans. And if you look at the world map, it appears to be in the roots of what we call the Polynesian civilization. It's around the Pacific Rim. So maybe it's something genetic in it. So that's my personal sort of view on this.
Right, they came through the Bering Land Bridge.
Yeah, sort of,
if I may make one small suggestion, since you're worried about MDR1, I guess, I would suggest that perhaps your etoposide would be best applied as an infusional therapy because infusional therapy helps override MDR1. If there are no other questions, then I would like to thank the speakers for, all the speakers in fact, for stimulating and exciting presentations. And I'd like to thank you, the audience, particularly you stalwarts who have stayed, for your enthusiasm, your interest, and certainly for being here. We look forward to seeing you next year in Hong Kong. Thank you very much.